to the questions about the pandemic on Newsy. And we want to do that tonight with help from Dr. Lisa Larkin in Cincinnati. She's an internal medicine and women's health specialist. Dr. Larkin, thank you for joining us tonight. Going off of Lindsay's reporting that we just heard right there, if someone has a severe enough case to need a ventilator, are there other options for them?
So the other options that you talked about are really not as good as mechanical ventilation, but you brought up all the very good points that with this illness, patients require many, many days on a ventilator. And the longer they're on a ventilator, the more apt they are to have complications and the mortality really goes up. And so everybody's looking for other options in those patients that may be borderline and you're trying to keep them off the ventilator a little bit longer. But mechanical ventilation is still clearly for those patients that need it the best way to oxygenate patients in people who have significant lung disease, like we see with COVID.
And Dr. Larkin, something that has surprised me in all of this that I didn't know is that even though we have all this technology, some of the technology is still pretty rudimentary, like turning the patient to their side, turning them over, and just hoping the body can, recover on its own.
Right. So the big thing with this is that there is a very significant inflammatory response. And so the lung process that you're seeing that's really impairing oxygenation is very serious. And that's why people are on a ventilator for much longer than we typically see with a regular pneumonia. And it's really this severe inflammatory response that makes the ARDS, we call it, very serious. And that's what's requiring longer oxygenation. And we're doing all these maneuvers now to help improve oxygen delivery when we're mechanically ventilating someone to get that oxygen to the tissues.
Dr. Larkin, we were talking about those new government models. They just tweaked it. It's now a projected 60,000 deaths by August. It was 81,000 just a few days ago. That's what we want to see happen. The numbers go down, down, down. Still a very serious number, 60,000 people. But what does it tell us about social distancing?
Right. So I think this was really good news today. 7 or 10 days ago, the projections were really 100,000 deaths on the low side up to 240,000 deaths. And with these modelings, what you know is the better data you put in, the better the results in terms of the more accurate results. And so what we saw yesterday was that the number was revised down to 80,000 and today down to 60,000. And that really is terrific news. Now, again, it's 60,000 more deaths than we wish that there were, but it's much better than 240,000 deaths. And it really goes to show the value of social distancing and how important that really has been in kind of controlling this pandemic. And we still aren't done. The social distancing continues to be important now, even though we're seeing improvement in the numbers.
We never want to jump the gun by saying, all right, looks good. Go to church on Easter, open the doors of your business on Monday, because it's still probably too soon. But I'm hearing talk of things like, would it be effective to take everyone's temperature before they walk in buildings? I've seen this written about out there before you go into the grocery store or church or business, that before you can come in, someone almost always has a temperature so they can easily find people.
Right. So, of course, there are things that we can do to try to identify those patients who have low-grade infections, who are shedding virus, and taking everyone's temperature is one way to do that. The problem is we estimate that about 25% of people have completely asymptomatic infections, and not everybody who has an infection actually develops a fever. And so it's not a perfect way to screen. It certainly helps identify more people who are shedding virus where you want to kind of keep them out of public places, but it's not perfect, unfortunately.
I see. And so the CDC guidelines that could be revised may entail some inherent risks. One more thing I wanted to ask you, Doctor, is your group is currently doing some antibody testing. What have you found so far? Is it different than viral RNA testing?
Right. So this is really important to differentiate. So the testing that we've been talking about for the last several weeks is really testing. It's a nasal swab or an oropharyngeal swab, deep swab, that you send to the lab, and they look for the presence of the actual virus, the RNA of the virus. And that is by far the test that you need to have when you're trying to determine if someone is actively infected. Now, there is some false negatives with those tests, meaning that the test would come back negative and someone could be infected, but it still is the gold standard. The antibody test is a completely different test. So this is when the body has an infection, you produce antibodies, different types of antibodies at different points in time in the infection. But antibody development is the body's response to the virus. And so if you can detect the presence of specific antibodies against the COVID virus, you know that that patient has been infected. And what we know is the IgM antibodies are the first ones to be developed, and those suggest an early infection. IgG antibodies are the type that come later, and those are the ones that provide long-term immunity. So when we vaccinate someone, it's the IgG antibody response that we want to see. And the hope is now, although we don't know yet, it's too early, that in someone who's been infected, who has detectable IgG antibodies, that that person is now protected from getting infected again. And we don't know how long they're protected. We hope indefinitely. We hope that this will be, for the rest of their life. We don't know that for sure yet. Data will come. But the presence of the IgG antibody means someone's resolved their infection.
Dr. Lisa Larkin, I am so grateful that there are such smart people out there like you who know what to look for and can help us get ahead of this thing and know that there is going to be hope, but it's through things like this. So Dr. Lisa Larkin in Cincinnati tonight, thank you so much for joining us. And also want to let you guys know that coming up later in the show, I am speaking with an authority on these antibodies who think they've found a vulnerability